Next speaker is Robert Skip Nelson, Deputy Director and Senior Pediatric Ethicist at the Office of Pediatric Therapeutics in the Office of the Commissioner at the FDA. Skip, thanks.
Thanks, Jeff. I put my watch up. I'm more an analog kind of guy instead of a digital kind of guy, but we'll see. So let me start off by saying thank you for the invitation. In the interest of time, I'll just go right to my remarks, but I need to start with the fact that I don't speak for the FDA. In fact, no one at the FDA has any idea of what I'm going to say today, and nor have they cleared it. I have no slides, and I've been listening intently, and it's unbelievable what I didn't know about mitochondrial disease until I've listened to what's been discussed. So I'm going to unabashedly say that we should evaluate this through the framework of subpart D as in dog. In other words, the ethical framework for the protection of children in research. Now, a couple of assumptions there. First of all, the issues with respect to the women that are involved are not unimportant. I'm just not going to address them. The focus is going to be on the interests of the child. I will say subpart B, as in boy, I think is totally inadequate for the ability to evaluate the appropriateness of what we're talking about today, which is the section that FDA does not have, but HHS has about research on fetuses. And I don't think in taking this position I'm talking about the ontological status of the fetus. I think you can talk about babies and not fetuses without referring to their ontological status. As a neonatologist, if I ever walked into a room and talked to a pregnant woman about her fetus, she probably would have punched me. It was appropriate to talk about the baby. So, the section we need to think about is when we talk about the risks being justified by the prospect of direct benefit and the balance being appropriate relative to the alternatives. Now, the National Commission framed this as clinical judgment. What I've heard a lot about in this last day and a half is what's the clinical judgment about whether you use this or not. And to tie this, I mean, I view it much as what Tom Murray said yesterday as trying to frame the appropriate boundaries of parental discretion. So that's how I approach subpart D. So what are the alternatives? Not to have children or to adopt. I'll just take those off the table. I think Heather Ward, Tom Murray spoke about that in terms of the desire to have genetically related children. Tom's words were deep, widespread, respected. I would agree with that. I would also refer to John Evans, who has left, about his public policy, about doing public bioethics and being consistent. We've crossed that bridge with ART. Unless you want to unring that bell has been rung. So, the other option is that are to be born with a mitochondrial disorder. Now, I don't think that's a good option, although John Harris's presentation may be to begin to think about, are there cell-based treatments that could be done postnatally? I mean, that was George Daly, his presentation, but I don't know if that's possible. And, you know, I don't think we want to rely on the natural lottery either. The other one is to use ART to prevent being born with a mitochondrial disorder, but the approaches there seem to be IVF with PGD or MRT. And my impression reading the literature is that if you have a homoplasmic or high-level heteroplasmic mutation, PGD is not going to help. And so there is going to be a group of women who are going to need this technology, and MRT is the only option. Now, I would group these together. I think what we are talking about here is prevention and not selection. I would disagree with Kevin's comments yesterday, but I don't, and I would also agree with Tom Murray, the non-identity problem is a dead end. I think it's a meaningful sentence for a child who is a result of this technology to say, the doctors took my mother's mitochondria out and put in someone else's, and I was born healthy, and if they hadn't done that, I would have been born with a disease. The word I there is referring to the same person, not two different people. So we could get into that philosophically, but you'll actually discover that I am very Buddhist in my thinking about whether there's anything ontologically real about anything. So, a whole different discussion. I'm not sure I'm the same person right now than I was a half an hour ago. But anyway, so let's get into it. First, in human children. So a lot of the discussion... That's right. Anyway, so going to the first in human children. So it's a common issue within the FDA. And basically, the extent to which when you have a severe disease and a limited number of alternatives, the judgment becomes very contextual. You heard that in the discussion of the non-clinical. It's case by case. What's the disease? What's the severity? The level of evidence you need, the degree to which you'll tolerate an uncertainty, all of that is placed into this rather contextual decision as to whether or not it's time to go forward. And there are situations where you don't have any human-animal data of adults to use. So the best animal model for children is an adult human with the same disease. You don't have that in many of these instances. And so you have to move forward. So what's the prospect of direct benefit? Born without mitochondrial disease, I think, is the primary one. With the mother's genetic heritage, I think, is the other one. Now, that I would say that's secondary, not primary. And the reason I say that is I think at this stage in the development of this technology, I would hope there would be a very strong line drawn between using this for severe mitochondrial disease or serious, as was discussed on the phone, and age-related infertility. And I know that that's outside of your task, but if you do say that it should only be limited in early stages to serious mitochondrial diseases, by inference, you're making the comment that it shouldn't be used for age-related infertility. That would be my suggestion as you work out your statement of task. Risks. Now, ART has risks, and those must be minimized. I'm going to make some suggestions there. If you take even singleton embryos that are implanted, I mean, there's a risk of a higher incidence of low birth weight, preterm birth, et cetera. So there are risks to ART that need to be considered there. And then you have the risks of MRT, and I think the one interesting thing that I've heard is haplotype mismatching and whether or not there needs to be haplotype matching. I think that sounds like an interesting conversation. But I would agree. So far, I've heard, in my view, no compelling reason to limit implantation to male embryos. I've not heard any compelling reason to do that. And that just tells you I'm not that worried about the germline downstream. I've found those arguments compelling. So what are the key features of a clinical trial, which is sort of what I've been asked to do, which is focused on the question of safety and efficacy. So first, severe disease is what I wrote. Serious, I hear, is what they have in the UK. We can debate serious, severe, but it sounds like we're all sort of in the same ballpark. The language of considerable risk gets to the question of transmission, and I realize that I didn't know as much about the sorting and mixing of mitochondria yesterday morning than I know today. So how much that carries through in terms of the risk when you have a woman of certain heteroplasmy into the fetus would have to be described. But at least as I originally thought about it, I would say that it should be a homoplasmic or high-level heteroplasmic mutation, ideally with minimal influence by the nuclear DNA. Now, why is that? Because if you're designing a clinical trial, you need to eliminate confounders, and the extent to which you're picking a disease that's got nuclear DNA aspects to it, then you're just confounding your outcome assessment. That would be the first phase until you get more safety data. Ideally, it would be onset in early childhood. Now, part of that is to think about risk-benefit with respect to safety, but part of it also is to think when can you get some meaningful clinical endpoints. So if you picked, for example, I guess some of the mitochondrial diseases that may, Alzheimer's and Parkinson's, I mean, we're going to be waiting for 60 years before we get any kind of clinically meaningful outcome. You could evaluate progression. But the other question is, could you use a biomarker? So does the epidemiologic data establish the fact that being below a 5% level of mutant mitochondria mean you're not going to have the disease? Well, if that's true, sounds to me like you don't need a clinical endpoint for the trial. You just do that to the endpoint of the biomarker. You evaluated it 8 days, or the issue of different tissues. You sort that out, and you could basically know that it's effective. It doesn't answer the safety question, but you could end up turning over your trial a lot faster if you don't have to wait till 10 years to get your clinical endpoint. My own bias is that you start off with women eligible for elective single embryo transfer. I mean, there was some issue of adequate oocytes, which I heard as well. But this would also reduce maternal morbidity and mortality and also reduce confounding by the fact that you're going to have all these preterm babies being born if you have too many multiple gestations. So your clinical endpoints and your follow-up, I mean, neonatal follow-up is complex enough. To confound it with all of your preterm birth, I think, would be difficult. Control group, not going to be feasible in terms of the serious mitochondrial disease. And so that's why you need to think about surrogate biomarkers and endpoint. 750 total in the U.S. by Doug Turnbull's estimate in the New England Journal of Medicine article. That's all comers. I mean, so if you narrow it down to serious mitochondrial disease, no control group there that's going to be possible. Other conditions, though, Alzheimer's, Parkinson's, you start getting into that once you've demonstrated safety. I think control groups are going to be absolutely essential for those kinds of diseases, because I suspect that's not related to just degree of heteroplasmy, but more nuclear mitochondrial interactions, at least my reading. Now, what about regulation? I've got 22 seconds. We'll get through this. It's a manipulated product. My view is it requires an IND. I was very happy to hear about that letter that was issued in early 2000s. So what is it? If it requires an IND, I think the FDA should take a strict enforcement. Again, this has not been cleared, so don't interpret me as speaking for them. We can put a study on hold if it's an unreasonable risk. And so if, in fact, using this technology is an unreasonable risk for age-related infertility, we can just say no. We have that authority. We don't need further. We can use an advisory committee process necessarily to extend it. Now, we can't use it to talk about INDs unless it goes into closed session. But it could be used to say, okay, here's what we've done in this disease. Let's move on down. When is it time to start doing Alzheimer's? We have that process. We do have the authority to require follow-up registries and risk evaluation management strategies, but we have no authority to require people to participate in them, and you heard Celia mention that. We can require it as long as, and then finally, to wrap our heads around it, who's the subject of this research? Now, I would say that the child is a subject of the research, but to some extent it gets, again, back to the child is the recipient of the test article. The child is actually the test article. So if you are the test article, are you receiving the test article? Wrap your mind around that. Clearly, the woman who will become pregnant is receiving the test article. But I would argue we should consider that child a research subject, and because of that, that's why I would apply subpart D, because I think it's much more useful. So I will stop there.
Skip, thanks for a very rich set of ideas.